Welcome, everyone. We're delighted and thrilled to welcome you to this webinar today. I'm Sarah Allen. I'm the director of the North American Observatory on Health Systems and Policies and associate professor with the Institute of Health Policy Management and Evaluation at the University of Toronto. We are delighted to kick off a new series of reports that are available online, profiling the health systems in North America as part of the European Observatory series. So this is really done in partnership with our colleagues in Europe, and we're delighted to have representatives from the European Observatory to speak to us today as well. Today's webinar will be organized with some brief overview of our speakers today. We will turn it over to my colleague from Europe to tell us about this series of health system reports. Then we will share some highlights from the North American reports specifically. These are available for you to download. They're relatively short reports, but we only have a few minutes, so we're only going to share a few highlights from each in order to provoke some discussion and debate around how we might draw learnings from the diverse experiences and levels of performance in different areas across these three countries. And we'll have some time for Q&A. So please keep your questions in mind as we present, because we will have time to hear from you, whether using the chat or you can unmute and ask your question directly. So that's the order of events today. We will be recording so that we can post this on our website. We won't record the questions, but we'll record everything else. So we will have this as a resource to share and come back to share with your friends and colleagues. So briefly, our speakers are authors of the reports as well as leads of the series. And we're pleased to have a discussant from the National Institute of Public Health in Mexico, Andres, to provide some remarks as well. So you see the bios here. We'll hear from each of the speakers today, and we look forward to hearing from you as well. So in the first instance, to kick off the webinar and really to situate our health system reports into the broader series, I'm going to turn it over to my colleague from Europe, Bernd, who's going to speak about this series and provide some of that context. Over to you, Bernd.
Yes, thanks very much, Sarah.
You are muted, Bernd.
Sorry. Yeah. Thanks very much, Sarah. It's a huge pleasure for me to welcome you on behalf of the European Observatory on Health Systems and Policies to this webinar today. And yeah, I wanted to say a couple of words about the series as a whole. You may ask what this is all about. And in fact, it's only one of several country monitoring products that we as the observatory produce. There are much more detailed reports, the health systems in transition reports, which is a different series, which we are not talking about today. But there you will find all the details about the health systems that you could be looking for. The insights are a series of much shorter health system reports, and they are specifically looking at countries outside the European Union. We launched the third edition of the series in January this year for 15 non-EU countries. And in March, we added Azerbaijan as the 16th country, and we are in the process of adding Andorra as well. And now I'm very excited that we can add the 3 North American countries to the current edition of the series. I want to thank my colleagues from the North American Health Observatory and, of course, the authors of the reports for all their hard work in preparing these reports and bringing them over the finish line. Sarah, next slide, please. The insights provide clear and concise overviews of health systems. They provide also actionable insights on challenges, progress, and opportunities. They follow a common structure that enables comparison between countries. They are based on internationally comparable and reliable data. They allow to monitor the development of health systems over time, and they are an entry point for discussions on where improvements are possible. Let me now pass over to my dear colleague from Mexico, Miguel, who will present key findings on his health system.
Thank you very much, Bernd, and thank you very much, Sarah, for organizing and hosting our presentations today. I want to acknowledge my co-authors, Mariana Morales, Hortensia Reyes, Diego Hernández, and Otilio Reducindo Maldonado. Mexico's health system is structured through four broad principles of social security, corporate health, public assistance, and market and charity provision. They ensure wide public financial protection, today reaching 85.4% or thereabout. This figure actually is at the beginning of this decade, when Seguro Popular covered 43.5% of the population with guaranteed interventions. However, in 2019, Seguro Popular was substituted by first an institution called INSABI, and today IMSS Bienestar. And today the figures of affiliation are not fully clear, although IMSS Bienestar does have an affiliation component. It is not mandatory for individuals to receive free care. So we are not altogether clear on financial protection, but this will become more clear as we present more specific data. Importantly, Seguro Popular was a pay for affiliation scheme, so the states received a capitated fund for each affiliate. And today, it works more like a historically based funding, where each state receives an amount based on the prior year's funding, regardless of the actual affiliation, if they indeed make progress with that at all. Each of these components, except the market and charity, is fully integrated vertically, with funding, provision, and coverage being integrated by the same institution. In the case of the social security components, it's for the formal sector population, in the private sector, or in the government, or governments at the state level. Importantly, however, every year, more or less, this is a study we did in 2015, but still valid today, up to 38% of affiliates lose their affiliation due to the change in employer from the formal to the informal sector, most of them then being catered for by the public assistant component. Today, considering all 100% of the population covered by these three pillars, IMSS covers 41.4%, and public assistance 48.8% of the population. Now, looking at it in history, this system was instituted in the context of the Second World War, based on principles formulated by President Obregón in the 1920s, when Mussolini in Italy instituted for the first time employer-based schemes where the state was the main promoter and indeed the main actor forcing or obliging affiliation. This scheme was then copied in Spain by Franco. Yet these segmented systems in Spain, in Italy, as well to an extent in Portugal and Greece, were transformed starting in the 70s, in Spain in the 80s, and later in Greece, towards universal health systems based on the UK's NHS. In Latin America, also in the 80s, Brazil substituted its segmented scheme with a universal scheme, the National Health Service. And in Chile, it was also substituted, although following different principles. My message here is that Mexico is long due for an in-depth reform, and that Seguro Popular, in spite of its advances, instituted public assistance as another pillar, although closer to Social Security. And with IMSS Bienestar today, it has become a centralized scheme, similar to IMSS insofar as a national agency structures all the system. However, there is an overflow across the pillars, and we can see this in terms of the private sector and in relation to the public sector. The public sector caters for 51% of consultations, and the private sector 49% of consultations. This, in fact, or in spite, the fact that the public sector funds theoretically an official coverage of 85% of the population. So there's a gap that is being filled by the private sector, yet these two sectors do not coordinate. The public sector does not fund any of the private sector operation. There are no schemes to coordinate care, to make referrals, to share data, and so forth. So they operate completely in parallel, implying a fragmented system. Current health expenditure in Mexico is the lowest of all OECD countries and remains below the average in Latin America. Even countries with a lower GDP per capita than Mexico, such as Brazil and Colombia, have a larger per capita spending. Between 2010 and 2020, healthcare spending grew annually, reaching 6.2% of GDP in 2020. In this last year, the growth was mostly due to the pandemic. However, due to fiscal deficits in the government as a whole, in 2025, we are living an important reduction of 11% of health funding for the sector as a whole. However, the non-insured suffered a 25% cut in funding, whilst the insured, those in the social security sector, in fact, saw an increase of 11%, thereby emphasizing the inequitable character of the Mexican health system, that instead of bringing it together under or bridging these gaps under a government that has correctly prioritized the poor in Mexico in the health sector, this trend is not showing. In terms of out-of-pocket spending, this is higher in Mexico, disproportionately so than of comparable countries. Out-of-pocket spending was reduced partly through efforts by Seguro Popular, with a reduction from 43.5% to 38.8% of total spending between 2010 and 2020. However, even at the end of Seguro Popular, still 2.5% of households experience catastrophic health expenditure. And even though poverty has decreased with the current administration, out-of-pocket has increased and posing, again, a challenge for improvement. In terms of resources, Mexico lags behind comparative countries in both nurse and physician population ratios. We can see Mexico lagging well behind all other Latin American and OECD countries that we have used for comparison. Also, this lag is also evident in hospital beds, with 1 bed per 1,000 as against 1.2 and 1.7 for Costa Rica and Colombia, respectively. And of course, shortages are exacerbated in rural areas that are increasingly difficult to serve due to the violence that is affecting our country, especially in rural areas. While Mexico made important advances in health indicators since 2000, comparable countries made even greater progress. Infant mortality was reduced in almost half between 2000 and 2020, as we can see here. But decreases were even larger in countries such as Peru and Brazil, starting with rates that were higher than those of Mexico, yet finishing in 2020 with lower rates than Mexico. Non-communicable diseases, mainly ischemic heart disease, diabetes, stroke, and renal disease, have continued to increase. Importantly, kidney disease rates in Mexico are up to 12 times higher than those in the USA and Canada. Excess mortality associated to the pandemic was 41% and was amongst the highest in the world, mostly due to issues in addressing public health interventions, and especially social interventions. Yet Mexico has a strong public health system and was a pioneer in policies towards healthy lifestyles. Excise tax on sugar, sweetened beverages led to a 5.5% reduction in consumption, and alcohol screening programs for drivers of vehicles in major cities led to 23.2% reduction in traffic-related fatalities. The good news are that just yesterday, the government announced the proposal to double the excise tax on sugary drinks and to increase by 32% that for tobacco. These are, of course, very good news for public health. Importantly, we should make sure those funds are used for health and not only to cover for the fiscal deficit. Thank you very much.
Thanks, Miguel. We're going to transition to the United States, moving north, and I will invite my colleague, Andrew Barnes, to present on behalf of the authors of the U.S. report.
Thanks, Sarah. Thank you, Miguel. It's hard to follow that. Great job. I'm Andrew Barnes. I'm here in Richmond, Virginia, United States. And my co-authors, Tom Rice and Lynn Unruh, have been working with me. We've been working together, gosh, since 2011 on these kinds of books. So it's been really wonderful. I started this process when I was a doctoral student, and now I'm a professor. It's been a lot of, it's been really great to work with so many fantastic colleagues. Next slide, please, Sarah. So here is a sort of schematic of our healthcare system today. Some key features of the way our health system is organized is that, as is true in Mexico and Canada, we're a federalist system where states or provinces, in the case of Canada, have a lot of authority and autonomy. And so we have states play a major role in provision of health insurance, for example, particularly for low-income families. We historically didn't have any significant public coverage until 1965 in our country. And that's sort of when Medicare, which is our sort of public insurance program for older adults, and Medicaid, which is our public insurance program for low-income families, was founded. Prior to that, most of the coverage that we had, and still to this day, most people are in employer-sponsored insurance, which is really an artifact of World War II, and some favorable tax laws in combination with some wage freezes that happened during the World War II. That, to this day, we have, a large swath of our population, including myself and my family, in employer-sponsored private coverage. Let's see. I think that, what's interesting about this schematic as well is that despite the fact that we have such, heavy involvement by the public sector in healthcare delivery and finance at least. We have not, as a country, done well to leverage our purchasing power, our monopoly power as a public payer, and we'll talk more about that in a minute. So some other key features of this is sort of this is after the Affordable Care Act was passed in 2010, which is the sort of most significant health reform since the 1960s, since Medicare and Medicaid were founded. It was a significant health reform, but I would note that it was incremental, and that what it really did was expand the existing public and private markets, and in doing so, reduced the number of uninsured from about 50 million in 2010 to about 25 million today, so about half, largely through expanding coverage for low-income families, Medicaid, across the states, and expanding the individual insurance market for private insurance, and also standardizing that market a little bit, and an employer mandate as well. So next slide, please. So despite the fact that we have about 92% of our population covered in the United States, you can see that we have a large proportion of individuals, particularly those without insurance, reporting that they had delayed or did not receive medical care due to costs. And you can see that 37%, that green line at the top, that's prior to the Affordable Care Act, and that's where we had 50 million people of our, we're a country of about 330 million, to give you some context. So we had a significant problem with uninsurance and affordability of care. We still do today, right? So that's what that 36%, it hasn't changed much. And, I think it's worth noting that even among folks who are insured, like myself, we, about, 1 in 10 of us say, yeah, I didn't get medical care when I needed it because it was so expensive, or I delayed. That has a lot to do with sort of the depth of coverage, or like how much the insurance covers, right? So how much I have to pay out of pocket in addition to what is covered, even if I have coverage. So let's see. I think the other thing to mention is that I had said that the Affordable Care Act had sort of halved uninsurance from 50 million to 25 million. Well, now we're going to go in the opposite direction. So as of July 4th, we have what we recall here, the one big beautiful bill from our current president, President Trump. That's going to add another 10 million individuals who are uninsured to another 10 million people will lose coverage as a result of the policies that were passed this summer, which we can talk more about in the Q&A if you'd like, with the majority of those those folks who are losing coverage, about 7 to 8 million who are going to lose coverage, are going to be low income or lower income individuals who would have been on Medicaid, our public insurance program for low income adults, but no longer will. So we can talk more about that. So we've made a lot of gains in uninsurance, but those gains are being reversed over the next decade. Next slide. Thank you. So what's really interesting about this slide to me is the share of spending that's public spending. We are about nearly 60 cents of every dollar that we spend in this country on healthcare is public dollars. That is just really surprising to me, and continues to surprise me that it continues to go up, right? It's increasing. And again, as an economist, someone who has an economic background, it boggles my mind that if I'm buying 60% of the apples in the market, I don't get to set the price of the apples, or at least influence the price of the apples. And I think that's one of the reasons why since Medicare and Medicaid were passed in the 1960s, we have historically not wanted to intervene on prices as a government. And as a result, if you look at national health spending trajectory over time, after the 1960s, it just starts to it goes sort of off the rails, right? And it pretty much hasn't stopped, because what we've been doing in our country is expanding coverage with public dollars, but not using the power of the purse to control the prices and utilization of how those public dollars are spent, which is a recipe for private private markets to and privatization and commercialization to sort of run these markets without a lot of management by the government. So you know, many of you know this already. I mean, shockingly, we spend $5 trillion on health expenditure. So that's the estimate for 2024. I'll say that again, $5 trillion. I started teaching this class 10 years ago. We were talking about, you know, $3 trillion a year. Now we're talking about $5 trillion a year, about 18% of our GDP. We are growing at about currently 7 to 8% a year in health spending. Our long run average is maybe 5 to 6% a year growth. So spending will continue to go up, even as coverage goes down in this country, right? Next slide, please. Yeah. So, you know, why do we spend so much money? I really do think it's the fact that we have done a terrible job of managing prices and competition in this country as a government. You know, yes, the slide, as the slide shows, we have more MRI machines, we have more CT machines, but we also have fewer hospital beds per capita, shorter lengths of stay. So, you know, spending is price times quantity, right? The Q, I don't think the Q is the issue in America. It's the P, sorry, in the US. We're all in America, sorry. It's the P that's the problem, I think, you know? And in fact, Uwe Reinhardt, well, as many of you may know him, one of my favorite articles ever is, "It's the price is stupid." That's why, you know, it's the prices. So yeah, next slide, please. So life expectancy. So here, you know, you see changes in life expectancy from the red dot in 1970 to like the greenish dot in 2019, and all of those are going up. That's great. But if you look at sort of where the US is, I mean, we were, you know, we're increasing, but, you know, our life expectancy is, you know, lower than the OECD average. It's lower than many of our peer countries. You know, it's currently 78 right now in the United States. The average, you know, life expectancy is 78 years. In Canada and the UK, it's about 81, I think, right now. You know, we have 40% of adults in this country are obese. 40% of children are overweight or obese. We have very high infant mortality. You know, Miguel was talking about infant mortality. We have very high maternal mortality in this country. We have very high overdose death rates, the highest drug overdose death rates, followed by, I think, Scotland and maybe Canada, I'm not sure. We have extremely high, you know, gun violence death rates as well. So, you know, we spend a lot of money. But it's also a very unhealthy place to be, and you don't live as long. So what's the value proposition, right? You know, for all that spending. Next slide, please. And I'm going to end here because I think it also reflects sort of the age that we are quickly moving into, and not just our country, but in Europe as well and other countries as well. There's a retrenchment of sort of like principles of equity. And so this, you know, we have for over 400 years been a deeply structurally inequitable country by design. So, and it's sort of evidence even today in this slide, you can see life expectancy for what we call minoritized populations, including African-American and Black individuals and American Indian, Alaska Native individuals, is much lower, on the order of, you know, 4 to 7 years lower than white individuals. You know, what's also shocking in this country is, despite spending now $5 trillion on healthcare, life expectancy went down. Some of this is due to COVID, right? But a lot of it's also due to our overdose crisis that we had as well, and crises of suicidality that we have. Life expectancy most recently is going back up in this country. We gained about a year most recently, but still well below the average of our peers. And so, you know, what's happening now in not just at the federal level, but at the state level, in many cases, is this retrenchment of sort of structural policy solutions to increasing equity and opportunity. And we are seeing an erosion of a social safety net and a lot of those policies that try to redress these issues of structural inequities of the last few centuries in this country. So these disparities, these differences across race, ethnicity, across urban, rural, across education, and so on, and income are likely going to increase in the near term if we keep following the current policy course that we have. So I'm going to leave it there and pass it over to Sarah.
Thanks, Andrew, for that really short but really compelling overview of the US report and some of the changes that have been seen since the reports were written. So I really appreciate that. I'm going to give a few highlights from the Canadian report, and then we will turn it to our discussant and open for Q&A. So just a reminder, please keep track of any questions. You can use the chat if you like. And one of the advantages of being the third presenter as we move from south to north is to sort of start reflecting on some of the striking similarities, but also notable differences. So I'll maybe highlight a couple of those as I present as well. And we all follow a similar structure to our presentations. You'll see some similar charts, and level of complexity varies as well. And so we'll see here in this org chart for Canada, it's a very simple diagram relative to the peers in North America in terms of, each resident of the province sort of has, falls within its a single payer model. And the role of the federal government is similar in the sense that they, don't play a leading role in delivery of services and financing, but relative to the other countries in North America, the system in Canada, importantly, is even more decentralized. So it's perhaps the most defining feature of the Canadian system is the level of authority held by the provinces and territories in terms of organizing and financing their own health systems, reforming them, et cetera. And the role of the federal government is much less in terms of the prescribing of setting of rules, and plays a smaller role in financing as well. So helps to keep that in mind when drawing any comparisons across. Also notable is the sort of feature of universal health coverage, again, unique in North America, where Canada has achieved at least some version of universal health coverage, a very narrow version, but the whole population is covered for this sort of narrow set of services that are, mostly hospital and physician services and diagnostics as well. So this is a quick overview of the org chart, and to sort of draw connections and comparison on financing, we can see a slightly different mix of financing with, as would be expected, a stronger role for governments in terms of the public component of the financing is much higher than the United States and Mexico. 2020 estimates were at about 73% of total spending was from governments, provincial, territorial, and federal. That was the highest ever just because of the pandemic, and now has since gone down back to around 70%. And we can also see a similar trend in terms of the growth. And we're following a similar growth rate, not quite as fast as the US, but of quite a higher growth rate on average for the healthcare sector than the economy generally. And so we see a growing spending on healthcare, but similar mix of financing. And we see, a much smaller role for out-of-pocket spending and private insurance than the other comparators in North America. But this is still playing an important role in Canada. And we're not quite in the trillions. We're only spending in the billions still in Canada, but it's a much smaller country at only 30-some million compared to 300 in the United States. So we have, we spend a little less than the United States. It's more comparable to many OECD and European countries in terms of a proportion of GDP, considerably more than in Mexico. And yet capacity is still quite limited in Canada relative to our peers. And this is just one indicator of the level of capacity in terms of the measure of hospital beds and supply of hospitals, which is quite low in Canada, the red bar, compared to other countries we commonly compare ourselves to. And, there's a declining rate of, declining sort of utilization of hospitals over time as they become more efficient and ideally better place, more community and outpatient care. But at the same time, there's significant constraints with the single payer model of healthcare that we have in Canada. We also earlier saw a slide around physician and nursing supply, and Canada is about the average for OECD countries in terms of nurses and a little bit below for physician supply. But that masks very wide variations geographically in the supply. So we might have major capacity constraints, much more so in rural areas and in Canada. And I think this geographic inequity and disparity is a really common challenge and concern, even in the very rich and resource rich place of the United States, where variations exist geographically. And hard to reach communities in Mexico and Canada are similarly facing challenges. In terms of the health of the population, I think, many of the comparative graphs that these reports show present Canada at one, a little bit on the upper end of those figures with, lower mortality rates from infant mortality, maternal mortality, higher life expectancy than in the United States and Mexico. And, it seems as though, also the trends are showing moving in the right direction in terms of improving population health generally. However, Canada is not a top performer relative to all of the OECD and especially the European comparators. So it's really important to select the comparators to inspire the type of high performing system we can achieve, and not only to look within North America to sort of feel like things are not so bad. That said, the graph I've shown here really shows the main risk factors that are affecting different age groups. And so we're visualizing this. Importantly, the data need to be updated. We do not have recent, really good quality data on mortality risk factors. However, these do show persistent challenges with the main, widely known risk factors such as tobacco, dietary risks. Also, obesity is a major challenge. And these, interestingly, like as Mexico is moving towards greater taxes on some of these products that are known to be harmful, this raises questions around whether Canada could do more in this area to try and address these persistent risk factors and target different population groups accordingly. So I'm going to just leave you with those few highlights. I hope we've provoked some questions. I'm sure there's much more we can think about and discuss, because these reports are really meant to be a springboard for discussion, really, as Bernd highlighted, just the starting point to open up the type of comparative work and discussion we could achieve. And so to kickstart our discussion, I'm going to thank you, Andres, for allowing us to end on a more positive note. It was a challenging set of, not uplifting slides that we've presented and shared, but we really encourage you to check out the reports. You can email us. You can see the huge book length studies that have been published for each of the systems as well. And we hope that this may have provoked some interest in looking across North America and drawing comparisons and policy learnings and insights. So thank you so much to our amazing panelists and authors. and to the team to help organize and produce these series. And thanks to Bernd and the European Observatory for bringing the North American Observatory alongside in this series. It's been really great to partner with you and wish you all well. Thank you for joining and have a great day. Thank you.
Thank you.
Yeah, take care.
Bye, everyone.